Dear colleagues, dear friends, good morning, good afternoon, good evening, wherever you are. I am Maurizio Cecconi and I am the President of the European Society of Intensive Care Medicine. I have the honor of chairing this webinar today with my friend and President-elect Elie Azoulay. The last years have posed massive challenges to our community. These challenges have shown the world the importance of intensive care units and intensive care teams for our patients, their families, and for the healthcare workers. While we cannot choose our challenges, we can decide how we respond to them. And solidarity has been a fundamental value to the response of our community. Thanks to the solidarity and joint efforts of healthcare workers, researchers, citizens, in some parts of the world, COVID-19 has become under control. But in many areas, the pandemic is far from over. We need to remember these parts of the world that are still fighting COVID-19 and help them now and in the future. In the recent weeks, the world has been shaken by the Russian invasion of Ukraine. So naturally, we condemn it, as we condemn every armed conflict. Thousands of people have died. Recently, the news reported that healthcare workers, some from our ICU teams, have been injured. Some have been killed. Our thoughts go with them and their families. This webinar series is one of the actions that we have taken to support Ukrainian colleagues who we have been in contact continuously over the last few weeks. We have admired their passion and commitment to save lives. We are learning from them and have asked them how we can support them. So we are working to prepare training materials and training sessions. This is the reason for choosing these topics for the first webinar. For instance, today, Triage and ICU. The option comes from our friends and colleagues there. Many of them are connected now, and please welcome them with me, and please make sure that you ask questions through the chat. We will monitor the chat and we will try to answer as many questions as possible, I'm sure. This Alive Solidarity webinar series that we open today will not focus only on war topics. We will carry on with a broad range of issues and make these and other resources free to help where and when it is needed, everywhere in the world. Let me say that this has been possible only thanks to the trust and support of our members. We have grown in numbers, so thank you. Thank you for supporting us. And thank you also to the donations that have been made to the Alive Fund. Solidarity is what has allowed us to go out of the darkest days of the pandemic. Solidarity is what is needed now. So with this, I am very happy, very honored to start and to give the floor to the first speaker of this webinar. It is a pleasure to introduce a friend, a colleague, Professor Jozef Kesecioglu. Jozef is a professor of intensive care medicine at the Department of Intensive Care Medicine at the University Medical Center in Utrecht in the Netherlands. He has been the chair of the Department of Intensive Care Medicine in Utrecht between 2005 to 2020. Among many roles, Professor Kesecioglu was a chairman of the ethics section of the European Society of Intensive Care Medicine. He has also represented ESICM in the work group concerning the statement about responding to requests to potentially inappropriate treatments in intensive care units. And he has been the president of ESICM between 2018 and 2020. Jozef is a very good friend. I had the pleasure to be with him, and he has led the society through some of the most difficult days of the pandemic. So it is my pleasure now to give the floor to Jozef for the first lecture.
Good afternoon, dear friends and colleagues. It's a big pleasure and honor and privilege to be for me to be with you this afternoon. And I hope during the next 20 minutes of my presentation, I will be able in these difficult times to give you some information which you may use in your daily difficult life, and maybe it will give you some guidance. ICUs are increasingly important departments in hospitals, my dear friends, and modern intensive care dictates that the responsibility of patient care and decision-making rests with specially trained intensivists. The selection and admission of patients is actually our daily task. But however, the rules start to change when large number of patients need to be admitted during times of crisis and mass casualty. That's why I will start my talk with our daily duty and the challenges that we have. And I will slowly make the change to the crisis situation during mass casualties. If we look back, we see that we have a challenge already between two concepts. And the first one is the rule of rescue, and the other one is cost effectiveness in selecting our patients to admit to ICU. The word cost effectiveness, I must immediately say that I dislike a lot, because it emphasizes all the attention on the money, and I cannot deny that there are some financial aspects of it, but it is more than the financial aspects. And we will see in the coming slides that it's more about helping as many people as possible. But you see actually that there is a tension between aiming to rescue identifiable individuals who need immediate help, regardless of costs or whatever the manpower it takes, versus aiming to do as much good as possible with scarce resources. If you look at this statement from Albert Johnson, already about, I think, 30 years ago, it was in 1986 when this was being said, you see the logical and also emotional statements relating our job, like throwing a rope to the drowning, rushing into burning buildings to save lives. And he extrapolated this thought to artificial hearts, our mobile critical care units, with a question at the end: might a world with less cost-effective healthcare be a morally better place to be? It was quite a relevant question, and you see actually that this statement goes very deep into our moral values in becoming a physician. But again, the world is changing, and we see the challenges here that the rule of rescue, the way it is stated in Johnson's statement 36 years ago, may certainly rescue patients facing imminent death, but also it may divert resources away from care of other patients. So it is very difficult to find the balance in between. And then I switch immediately to a Dutch statement, and I have, in order to elaborate more, I have translated it word by word from Dutch to English, which makes it a little bit difficult to understand, and that is: treat equal cases equally and unequal cases unequally. What do we mean by that? Our core business is concerned with the medical state and the need of the patient. So we all agree that social status, gender, race, religion, sexual orientation, or any other sort of differences among the people should not play a role, does not play a role, and certainly, again, should not play a role. So this makes actually the statement, treat equal cases equally, effect. That means that rich and poor people are equal in terms of medical demand and need, and should therefore be treated equally and accordingly. However, the complaints and the sicknesses of people are unequal in terms of the medical demand and need. And therefore, rich and poor people here are not equal, because one of them might have more severe sickness, which has to be treated before, and it could be that the rich person is treated before the poor person, so the priority is given to people with acute complaints, which brings us to the concept of unequal cases will be treated unequally. I don't know whether this helps a lot, but it may help if we switch from here to egalitarian and utilitarian concepts. If we translate egalitarian and utilitarian approaches to ethical situations, we will see that there is quite a difference between these two concepts. Because the egalitarian approach states that the acutely ill patients will always be treated first with the egalitarian thinking, and it gives then the priority to patients who are the worst off in health compared who are not. We have seen this happening, for example, in COVID-19 pandemics. The patients needing a planned operation were being cancelled because the priority went to patients who were the worst off in health. They were the COVID-19 patients. And of course, people were operated when the operation was needed very, very urgently. This is the egalitarian approach. Also, the egalitarian approach is giving priority, the state of giving priority for patients in acute emergency. This is very much in line of the so-called rule of rescue, which I have mentioned from Johnson at the beginning of my talk, which is again standing for someone in acute need. The person must be rescued. Whereas the utilitarian approach, it approaches from a different aspect, from the point of view that if all the resources were made available to the sickest patients, with sometimes no real chance of recovery or very low chance of recovery, the ICU capacity will always fall short, even in normal times. I'm not even talking only about crisis times, but even in normal circumstances, we use our scarce resources with restraint in patients with a poor prognosis. This is actually from our daily life. Utilitarian approach advocates to use the resources in such a way that the best possible effect on health is achieved for as many patients as possible. So it is actually not in terms of terminology, this is actually not, it cannot be good explained with cost effectiveness, but this is maximizing health gain. The problem here is the bedside rationing, which is following either the utilitarian approach or crisis situations with the mass injuries, mass casualties, because the physicians are faced to make decisions about the distribution of ICU bed in times of scarcity of the ICU capacity. And these decisions are sometimes contrary to the medical interests of the patients, of the physicians, our patients. And we have to take sometimes decisions according to these concepts, which will be against the interest of the patients whom we are treating in order to meet the needs of other patients. And this is difficult. For example, discontinuing a treatment in a patient who has a very poor prognosis in order to make a bed for an ICU for a patient whose prognosis is better in terms of scarcity, in terms of crisis. Sometimes this is unavoidable. From the perspective of utilitarian thinking, bedside rationing entails us maximizing health gains as a consequence, as a positive consequence. But there is the other side, the flip side of the coin here, because there is also the negative. There are also the negative consequences, because bedside rationing can also cause huge emotional stress and various role conflicts among the physicians who have a double role here. The physicians may also start to feel that they have to defend their patients, but they have the moral load that at the same time they have a responsibility towards the other patients just waiting at the door of the hospital or at the door of the ICU. And they have to deal with these patients with scarce resources. And it confuses the physicians because they don't know what they are at a certain moment. Are they a lawyer of the patients that they treat? Are there a traffic police sending one out and accepting the other? Or are they playing the judge, deciding who would come in and who would have to go out? And this makes this makes the psychological situation of the physicians very difficult. We have to accept one thing, that the need to allocate scarce resources is inevitable, especially in a crisis situation when there are mass casualties and the people are coming more and more in big numbers in our ICUs. But because of the negative consequences and risks of the bedside rationing, individual physicians will feel uncomfortable with the idea that this responsibility lies too much in their hands. After all, our training as a physician is based on treating the patients, but also to do the best for the group of patients, but it is still a difficult situation. And I think the physicians need some help there. So the first thing we have to keep in mind is that the distribution of scarce resources in the clinic should be done according to a fair, transparent, and consistent strategy. This strategy, ideally and preferably, will not be determined by the physicians at the working floor, but at a high organizational level, not only in the hospital, but in the healthcare system of the country. A national healthcare system strategy should be there available in order to take the big pressure from the physicians away. A clinical ethics committee could play a role in this. Let's be careful here, because when I say ethics committee or a triage committee, I don't mean that this committee members should be doing the triage themselves. These people, this committee will be playing a role in supporting and legitimizing the bedside rationing decisions. They are not actively performing it. I will come back to that in one of my last slides. This will result that the moral stress related to the distribution of scarce resources can be, maybe not fully, but at least partly removed from individual physicians. I'm giving you now some examples of bedside rationing, which we used in Dutch ICUs during COVID-19 pandemics. I have changed the phases in order to adapt it to my talk and also to simplify it. And I begin with phase 2 because phase 1 is normal times. And phase 2 is when the beds start to get scarce. Phase 2 is still a milder form of bedside rationing. So the selection is still made on medical grounds. Like patients with certain diagnoses do not receive ICU treatment, like unwitnessed cardiac arrest or severe neurotrauma or massive stroke. These are a few examples. And also the patients with a life expectancy of less than 1 year or a frailty score of 6 or higher are also not admitted to the ICU. This is a little bit the summary of it. So I'm just giving it as an example. And then I'm moving to phase 3. It is still on medical grounds. The selection is still on medical grounds, but stricter medical grounds, like patients with a frailty score of 5 or higher are not admitted to ICU. ECMO is no longer offered, and long-term resuscitation is no longer performed. And here it may be necessary to make a choice between more than one candidate for one ICU bed. So we are actually moving towards the triage of the patients. In phase 4, triage is made, and especially on non-medical grounds. However, the first bullet shows some semi-medical ground decision, which is the priority given to patients who are expected to remain short in the ICU. Again, another step is the priority given to younger generations. And last stage would be perhaps the most unpleasant one, and that is drawing lots among the patients who need to be admitted. In this situation, my dear friends, it is also important that the triage criteria apply to all of the ICU candidates, not to a certain group of patients. I will finish my talks with a couple of recommendations. The first slide is, have your bedside rationing rules ready, preferably at national level, preferably during normal times, so that you don't need to start and thinking when the crisis is there, right, and you are right in the middle of the crisis. The documentation should be ready so that everybody know how to act when the mass casualties occur. Make sure that caregivers who have to make sharp choices feel fully supported. Allow stricter selection at the hospital level for ICU treatment. The selection should not only begin at the door of the ICU, but it should be done at other levels of the hospital first. Ensure that this selection is made according to fair, transparent, and consistent criteria, supported at an organizational level in order to reduce the negative consequences and risks of bedside rationing for caregivers and patients. Make sure that these criteria are practical so that it is possible to use it by healthcare providers easily. Involve the triage committee in providing policies and guidance for clinicians to help to ensure equity in the application of rationing under crisis standards of care. And then we come to the triage team, appoint a triage team, which is different than the triage committee. And this triage team can have intensivists in it, can have associated medical specialties in it, but they should not be the ones working at the bedside. They should not be the ones who are taking care of patients in intensive care at the same time, at the same time frame that they are also doing the triage. This is in order to take the responsibility over from the physician at the bedside to avoid double function, that you have to take care of some patients and at the same time you have to triage the other ones, and you have to maybe take a decision about a patient that you are taking care, thinking the other one at the door. This is too much for the physician who is at the bedside. That's why it should be done by a triage team. And my last bullet, which is, I think, a very important one, make sure that nobody will be held responsible for the policies and practices once the crisis is over. Thank you very much for your attention, and I wish you all strength in these very difficult times. Thank you.
Thank you very much, Jozef. Thank you very much, Professor Kesecioglu, for this very important and very thoughtful lecture. We are going now to move to the seventh presentation. This is my great pleasure, Dorohi Kolehi, Dorohi Druzi, dear colleagues, dear friends, to show you that solidarity, that is an awareness of shared hopes, that we are sharing the same hopes today. And to get together, to be bound together. And we are here together today to support our colleagues from Ukraine. And ESICM has at heart to express its solidarity with all of you. With the ESICM president, Maurizio Cecconi, all the officers, all the people working at ESICM office, we are thinking of you every day. I'm delighted now to introduce Professor Charlie Sprung from the Critical Care Department of the Hadassah Medical Center in Jerusalem. Professor Sprung is a worldwide researcher, very well known and very famous. He has been the chair of the ethics section and has had many other positions at ESICM. He's one of the most prolific researchers in critical care overall and in ethics in particular. He has been the one leading many guidelines, in particular on triage. And we are delighted to have now Professor Sprung lecturing on the guidelines for triage. Thank you very much, Charlie.
Thank you very much. It's an honor to be here today. My heart goes out to the Ukrainian people, especially to the healthcare workers who continue to care for their patients under these terribly difficult circumstances. I've been asked to talk about ICU triage today, and since I really don't know exactly what the resources are in the different Ukrainian hospitals and what the needs are, I thought it best to talk about ICU triage under normal circumstances, mass casualty situations, and also the pandemic, the specific pandemic of COVID-19, which we've been taking care of recently. And hopefully some of the information I can impart to you today will help you care for your patients and improve their survivals. Now, there are various ethical principles that we're all familiar with. And under these crisis situations, a lot of these principles may not be able to be used as much as we'd like. Patients may not have an autonomous decision to decide to come to an ICU. We may want to have beneficence in caring and helping our patients, but we may not be able to care for them all. Non-maleficence, not to harm patients, but patients who are refused ICU may not be able to be helped and may be harmed. And we would like to have a fair share for everyone, and everyone could come into the ICU, but that may not occur under these circumstances also. Now, under these circumstances, we have a list of different criteria we could use, and as we will see, most consensus statements have gone with either medical benefit or a first-come, first-served basis. The first consensus statement was in 1994 by ESICM, and they looked for patient benefit. The American Thoracic Society, a few years later, looked for first come, first serve. Subsequently, there have been other consensus conferences. We had one after the ELDICA study, and Jozef in the ESICM had one talking about the history and using either patient benefit or first come, first serve. And when we had our consensus after the ELDICA study, the decisions to be made for all patients, 100% of the respondents said this should not be made on a first come, first served basis. Now, most intensivists assume we have an improved survival in putting patients in an ICU versus a regular ward. This was an Israeli study of 5 different centers. And you can see that the survival curves of patients in a general ICU or a special care unit, a cardiovascular or neurosurgical unit had higher survivals than those on a regular ward. I was, in fact, impressed by how many patients on a regular ward survived. And this may be because in Israel, 50% of the patients meeting prospective ICU criteria are taken care of on a ward, and our general physicians know how to take care of ventilated patients on the ward. Now, which patients who are admitted to the ICU have a better survival? Well, if we look at mortalities based on severity of disease here on Apache 2 scores, we can see that those patients with lower scores, if we look at the mortality differences between those admitted and those who are refused, there's not that much of a difference. There seems to be a trend in the more severely ill patients between those admitted and refused. But the main patient benefit in being in the ICU is in the middle group, those patients who are not too well and those patients who are not too sick. Now, should age be used for triage? This is part of the ELDICA study. It was a study of 11 ICUs in 7 different countries. And we can see as the age breakdown increases, the percent of patients being accepted decreases. Elder patients are typically refused. And if we look at the survivals, those patients alive in the different age groups, we can see that the numbers decrease and the mortalities are higher in those patients who are older. But it's not so much important what the mortality is, it's the differential mortality difference. And if we look at the mortality here of patients who are accepted in black and refused in gray, you can see in the younger age groups, the difference isn't that great. And as we get into the older groups of patients, the difference is greater. And based on that, the survival benefit is greater for the elderly patient as opposed to the younger patient. Now, let's talk a little bit about terminology. When we talk about mass casualty events, we're talking about real disasters, something like 9/11, where patients won't even make it to the ICU. If we look at multiple casualty events, something we unfortunately saw in Jerusalem with a lot of the bus bombings, you will have over a short period of time a large number of patients who are coming in which will not be able to be handled under normal circumstances with your ICU bed numbers. During the H1N1 epidemic, we had various recommendations through the ESICM. The ACCP had recommendations shortly thereafter that were published in CHEST, and these may be helpful for you. And during the COVID pandemic, a recent paper in CHEST talked about how you can change your ICU to develop improved care during surge crisis. Now, let's look at some of the recommendations. During pandemics and various crises, we will have many critically ill patients that will overwhelm the healthcare resources. Triage can be used to guide the prioritization of these limited resources during these disasters. And in severe circumstances with insufficient ICU beds, we will have avoidable deaths. We will have people who under normal circumstances would survive in an ICU, but now they won't be admitted to the ICU and will die. And developing fair and equitable policies means getting the greatest good for the greatest number of patients that Jozef talked about. And this may require restricting services to patients likely benefit from ICU care. And unfortunately, the usual treatments and the standards of practice may be impossible to deliver to as many patients as we would like. So we therefore have to restrict our ICUs to patients likely to benefit from care, and ICU care and treatments may have to be withheld from those patients likely to die. And in other patients, we may have to withhold or withdraw treatment after a trial in those patients do not improve or in fact deteriorate. So we may have to exclude patients who are not ICU candidates during these times, patients with a poor prognosis despite ICU care, patients requiring resources that cannot be provided. Perhaps we cannot provide ECMO under these circumstances, or patients whose underlying illness has a poor prognosis with a high likelihood of death, or those patients who are too well, who will do okay even if they're not admitted to the ICU. Now, the ICU triage and the different criteria we should use remains controversial. Some recommend still patient benefit, some first come, first serve, and each institution should determine its own triage criteria using senior clinicians in a transparent fashion to make these difficult decisions. All critically ill patients should be assessed by the triage officer, applying inclusion and exclusion criteria, possibly with a prioritization tool to determine qualification for ICU admission. Now, in this CHEST paper, they talked about a triage policy should be used to triage patient based on an improved incremental survival, something that I showed you the differences in mortality between those admitted or refused into the ICU, rather than on a first come, first served basis, with a substantial incremental survival difference favoring resources to another patient. And unfortunately, we don't have this kind of information during a crisis situation. And because of that, we can't use this kind of criteria because there's nothing objective to use. So based on this information, the statement was made that triage system based on limited evidence are preferable than those used just by clinical judgment alone. And currently, and things haven't changed since this 2014 statement, the most ethically appropriate method is to prospectively define patients who meet the ICU inclusion and exclusion criteria, and then consistently apply a prospectively developed objective protocol. Now, patients not meeting inclusion criteria remain on the ward. They can be reevaluated at a subsequent time, and all ICU patients at the time of the crisis will also be assessed for eligibility based on the same criteria. So if a patient didn't have COVID, once we had these emergency criteria and protocols to be used, patients who are already in the ICU would be evaluated based on the same criteria. And patients admitted to the ICU should subsequently be reassessed and recategorized based on these criteria, and then again, perhaps for discharge. When resources permit, emergency triage can cease in a graduated fashion and altering the prioritization criteria and the various exclusion criteria and thresholds which have been used for the crisis situation. Now, let me talk a little bit about COVID. COVID-19 was classified as a pandemic by the WHO in March of 2020. And at that time, speaking to colleagues in China, Spain, and Italy, they were pretty much overwhelmed by the numbers of patients coming into the emergency departments, the numbers that required ICUs, and they did not have enough ventilators, ICU beds, or PPEs. And various medical societies talked about using social worth or perhaps age, chronological age, as a reason to triage patients in or out of the ICU. Now, several of my colleagues who had been influential in developing our previous ICU triage recommendations realized that the situation here was much, much different than anything we had seen before in terms of the number of patients who were dying in emergency departments, not getting to see a physician, and not being able to be put on a ventilator and dying very quickly. So we put together a group and we decided on trying to think about different algorithms, different tools that could be used for this COVID-19 crisis. We felt that institutions should develop prospective objective triage protocols to enhance consistency and decrease provider moral distress, which is a serious problem for people making these kinds of decisions under these circumstances. Trying to maximize available resources, and the triage protocols should only be triggered when resources across a broad geographic area will or are overwhelmed. Now, in Israel, we had a national ethics committee make decisions. I'll talk a little bit about that later. But even though we never had to trigger the system and the algorithms that were accepted, many physicians did use the algorithm and felt that it decreased their moral distress because they were using something objective as opposed to making a clinical decision by themselves. And the strategy, as mentioned before, is the greatest good for the greatest number of patients. In this group, we look for incremental survival benefit, saving the most life years. The Israeli group decided on just saving the most lives without looking at the age and life years involved. And if different people had equal priorities, only then we would use a first come, first served basis. And I'll show you a little bit more about that soon. The main thing is this tool had to be simple, easy to understand and use, and most important, providing for very, very quick assessments because you had to move very quickly from one patient to another. And the triage algorithm should apply equally to all ICU candidates, both those with and without COVID. Now, we decided to use the same exclusion and inclusion criteria that were used under normal circumstances, so people would not think that they were second-class citizens and weren't given a chance to be triaged. And rather than starting with inclusion criteria, we decided to start with exclusion criteria. If someone met exclusion criteria, we didn't have to waste time to move to the inclusion criteria, and we can move on to the next patient because we had to triage so many patients. We developed a prioritization score, which was based on 4 different variables predicting short-term mortality. The first was a performance score. We decided to use the ECOG score, which was used for oncology patients and had been shown to work not only for oncology patients, but elderly patients, patients with pneumonia, and those admitted to ICUs. And the main reason was it's quicker, 5 variables as opposed to 9 variables for the clinical frailty score, and comorbidities, looking at ASIS score rather than other statements that had used a long list of comorbidities. A number of organ system failures, not the SOFA was complex, would take too much time, and previous information related to the H1N1 epidemic had showed that it was not very reliable as a predictor. And then the clinician's decision as what to the predicted survival was. We thought this tool should be flexible, adapted to local practice. So if in one country they were used to using the clinical frailty score, it was fine to use it if it would be quicker than using the ECOG performance score. Age should be taken into consideration with other variables, but chronological age should not be the sole determining factor. Should we give different priorities for healthcare workers, especially those infected by COVID? This was controversial, and we decided that each country should decide for themselves. In Israel, we decided that there should not be priority given to healthcare workers. Should we have, as Jozef talked about, a separate triage committee? Again, that should depend on each country. And in Israel, we don't have enough intensivists to both take care of the patients and to form a different committee. So we decided not to have a triage committee. Now, here is the algorithm that we came up with. You can see the exclusion criteria, the typical kinds of criteria if someone refused it: severe injury, cerebral injury, severe metastatic cancer or hematological cancer. Inclusion criteria, the typical ones requiring invasive ventilatory support or hemodynamic support with vasopressors. And if one met all the inclusion criteria, did not have any exclusion criteria, there was a prioritization, priority 1 through 4, based on these 4 criteria. The performance score, you can see the low scores, people who basically could perform very well, a low ASIS score, only 1 organ failure, and the predicted survival greater than 80%, as opposed to priority 4s, after cardiac arrest, not waking up, severe burn, severe dementia, and predicted survivals less than 20%. And if there was a question of tie breaking, we would allocate by incremental ICU benefit, as mentioned before. But if everyone was in a priority 1, and speaking to people in Italy and in Spain, a lot of times all patients were priority 1. Under those circumstances, we would look at first come, first serve. We would reassess patients afterwards and then later on decide whether patients could be discharged or not. Now, the ECOG performance score, you may not be that familiar with, but you can see 0 is fully active, minor restrictions for 1, and those with 3 or 4 confined to the bed or a wheelchair, confined completely disabled, and I think most people are familiar with the ASIS score. Here are the authors who helped provide this algorithm, which I think you may find helpful and read more extensively. Now, here's a paper describing the national policy we used in Israel, and this was not made up by physicians. It was a national ethics committee made up of various disciplines, includes ethicists, philosophers, and others. And the whole process, developing a model for an entire country's policy, can be seen here. I've talked about ICU triage. I've not talked about post-ICU triage, outflow and discharging patients, but I think we can discuss that more in the questions and answers. So what I've tried to do is give you an overview of ICU triage under normal circumstances, under crisis situations. We'll talk more in the discussion period, but if there are people who have not been able to be on this session who have further questions. On this slide, I leave my email address. If anyone has further questions, I'd be more than glad to answer them at a later time. Thank you very much.
Thank you, Charlie, for a great talk, and I am welcoming back everyone here, and also welcoming Claudio Sandroni. Claudio is an intensivist based at the Gemelli Hospital in Milan, and is also the chair of the Trauma and Emergency section of the European Society of Intensive Care Medicine. He's an associate editor for Resuscitation for Intensive Care Medicine. He's an expert, and he's helping us to build resources now on response to the request of our colleagues. Elie, I am seeing a lot of questions coming from our colleagues that are connected from Ukraine, and we're very happy that they are with us today, spending some time despite all the difficulties there. Would you like to start maybe asking some of these questions to the panel?
Yes, there is one question that raises a very important point, and the question is actually for the 2 speakers. It's about how these concepts have navigated over time, and where patients first provided with full resuscitation, and then decisions to adapt the goals of care have been made over time, or those ethical concepts are there driving the way we decide for the goals of care and didn't change over time, I would say, over the last 20 years. And when we look at the different guidelines that have been provided by the teaching critical care societies. So one question for Jozef is, where the ethical principles were needed to adapt to a changing critical care environment. And one question to Charlie is if you can summarize between the two sets of guidelines, those in the 19s and those that are more recent at the end of the 2010s, where are the main changes where our colleagues from Ukraine can learn from these changes over time?
Well, I think I can begin it that way, that I've been working the last 40 years in two different countries. And there is, of course, a cultural difference in between. And, of course, there is a difference in time, in my perspective. Well, instead of, I think, going back 40 years ago, how we were doing this, I think at this moment, it is not like that every single cardiac arrest should be resuscitated in the ICU. It is completely depending on the situation. You know, if you have a patient who is on the way of recovering and suddenly with a heart failure, having a rhythm disturbance and having a ventricular fibrillation, this is completely different than a patient who is very severely ill and we are just at the brink of thinking whether we should withdraw the treatment or not. It is not like that every patient before he or she dies is resuscitated once. And the decision is taken in an earlier moment. And there, I think we have quite a lot of parameters that we keep into consideration. I can give a few examples, but I think the list would be too long. For example, a patient who has been thoroughly resuscitated after an out-of-hospital cardiac arrest, where we do not know whether the neurological part after such a neurological situation, after such a long resuscitation, how it will end up. And if the patient receives after each other some rhythm disturbances, we may decide not to resuscitate such a patient. Or if we have a patient who has been having a huge history with incapabilities and suddenly ends in the ICU for an ICU trial. I don't like the word, but that's not the subject now. That's for some time later. And then during that stay, we have the history of the patient and we know all the comorbidities that the patient has. Okay, we say we have given the patient a chance, but if something happens, we are not going to resuscitate it. So I think in order not to keep it very long, it is not a rule that every patient dying in the ICU should at least once be resuscitated. And the decision can be taken well before there is a resuscitation situation, whether we will do it or not.
So, Elie, in answer to your question, I would say things really haven't changed that much. If you look at the original ICM recommendations in 1996, they looked at patient benefit. A few years later, the ATS in terms of first come, first serve. Perhaps we've refined things a bit better. And if you look at the algorithm I showed you in terms of the 4 priorities, I think we can identify those groups of patients based on the 4 items that we can assess to see which patients really can benefit more or not. And we should use patient benefit. And I think most intensivists would agree with that. But there are circumstances where we can tell. And different people in the same priority, under those circumstances, when we really can tell, then I think we probably should be using first come, first serve. Sort of what Jozef talked about, we had a recent paper that came out in Lancet Respiratory Medicine on worldwide practices at the end of life. And there are very, very big differences in different regions. We looked at 8 different regions in 36 different countries. And as opposed to my training in the United States when I was in Miami, when the 1970s, where everyone was resuscitated, in most European countries and around the world that doesn't occur. But there are certain countries, certain regions in, let's say, Southern Europe, Latin America, or Africa, where there's a lot more CPR going on than withholding and withdrawing.
Thank you very much, Charlie.
I would like to maybe to ask Claudio if you want to make any comments on these two questions before asking another one.
Yes, sure. As far as CPR is concerned, first of all, let's consider patients which have indications for ICU. So we are talking about ICU triage, and in general, patients in the hospital who don't have indication for ICU generally don't have indications for CPR, even if the opposite is not true, because sometimes you can admit patients in the ICU who are treated, for instance, for an aggravation of a chronic disease, who are taken to ICU to provide, for instance, ventilation or some kind of care for which ICU is indicated, but CPR is not, because they are in the terminal stage of an incurable disease. And generally, the very simple criterion which is used in our hospital, in which we have a committee for palliative care, is that patients who are in the terminal phase of an irreversible disease should not be resuscitated. Another problem may occur when the patient is already in ICU and you have to decide whether to provide CPR or not. But my understanding, even in absence of surveys, is that the doctors in ICU are very aware of what are the indications for CPR in their patients. And this is part of the, one of the reasons for the paradoxical, much higher survival rate of cardiac arrest occurring in intensive care versus those occurring in the ward. Because my general impression, apart from, of course, the speed of resuscitation, is that in that case, CPR is used much, much more wisely. And another criterion is brain death. So patients with brain death are not resuscitated. Another rather simple criterion is a terminal failure of a vital organ, like a heart or liver failure, for which there is no indication for transplant, nor for other form for artificial support. And just to remind patients who have been mentioned by the other speaker, or patients who have been resuscitated and have a severe damage or brain injury, ESICM has guidelines for prognostication in post-anoxic brain injury. They have been updated in 2021 and then can be used as a guide of care.
Thank you, Claudio. We're seeing a lot of questions on the chat, which I can summarize in terms of a theme about scarcity of resources and allocations. Some practical questions, maybe Jozef, you can start. Let's say that you are receiving several injuries that are coming from the OR, and some of them, well, many of these, they required a ventilator in the ICU, but you may not have enough ventilators. I mean, we're seeing something similar even with COVID. When would you consider disconnecting a patient from the ventilator? Maybe Jozef, you can start, and then Charlie's already expressed some of the strategies about this, but it's a practical question, and I think it's important we try to give an answer there.
I think I can handle this in two different categories, because normally it would be a very bad message if you suddenly hear on the phone that there are 3 candidates, and then you start to look around which patient can I stop with the treatment. That is, I mean, you may be pushed to do that, but that is something not very convenient. I think the ICU should way before decide daily whether the treatment of a patient at that moment appropriate is or not. That is much more convenient from my point of view, and in most of the cases that creates you some space when you are faced with 3 patients in order to admit because you have an empty bed from the decision that you have taken way before because of the other patient. Well, there are exceptions, of course, because I have put the scenarios that we used in COVID-19. Luckily, we never went to the 4th scenario, that sometimes you will have there 3 patients And I would say that if that moment coincidentally we have a brain death patient, it makes the situation easy. But it is a very, very difficult situation suddenly, a patient who has a chance of survival. I mean, if the patient has no chance of survival, again, we should take the decision beforehand. But sometimes we know that patients have some chance of survival, even though that may not be considered to be high. That patient, to take the patient out of care and put the other one, I think it's a difficult decision. If we have to do that, there must be a very good reason for that.
And if I can just make a comment from your talks, Jozef and Charlie, you were also showing, this is an approach which is a team approach. It's the whole hospital that needs to be in this state of understanding that we are in this situation. And as I said, we can only feel for what is happening now with our colleagues and facing with these massive dilemmas. But what we had some difficult situations with COVID, is the whole hospitals and all the decisions that are trying to be made before you go to that moment.
Yeah, Maurizio, if I may add one thing, in order to prevent a misunderstanding, not being able to admit a patient to ICU is not abandoning the patient. So that should be very clear. And I think Charlie can say something about that in your practice.
So I would agree 100%. And as you saw in the fact, under normal circumstances in Israel, we only have 50% of the patients who require ICU being in ICU. Those patients are admitted to the wards. They're on ventilators. Some of them survive, not as many as would be in an ICU. But clearly, during a crisis, where you have too many patients and you can't admit them to the ICU, you can put them on the ward and they can at least get palliative care if they can't get really, critical care. But even during COVID, I mean, there were some patients who didn't make it to the ICU. We recommended using the prone position, and some of those patients who we thought wouldn't be around the next day survived and left. Some of them even left the hospital. The question about ventilators is more difficult than the ICU. We can occasionally increase the number of beds in the PACU, the recovery room, or until there are enough beds, you can keep the patient in the operating room till you find a bed. Disconnecting a ventilator in Israel is quite easy because it's against the law. But in most countries, I think it's also problematic. It takes a long time to talk to the family, let them know what's going on. And as Jozef said, besides a brain dead patient, I think it would be very, very difficult to withdraw a ventilator to be used for another patient.
Yeah, I think you're answering for all of us in this. Elie, maybe another question?
Yeah, there's a very important question, and I think that the question is for the five of us. I have an 8-bed ICU, and I need to optimize the way I'm handling more and more patients in the same number of beds. We have all learned since these years of ICU, and the COVID pandemic has been a very good emphasis of that. We cannot open an ICU bed. An ICU bed is not a furniture. An ICU bed is an environment, is a team, nurses, doctors, materials, devices, drugs, etc. So we have the time. So we discussed triage. Triage is one option to provide the best ratio of benefits for at the patient level. We have the time-limited trials, and I agree with you, Jozef. The word is not nice, but actually it refers to something that is very concrete. Is to make everything for some days and then make the decision according to how the patient evolves. Do you have any other opportunities, possibilities to optimize an ICU bed? Can we make better decisions? Should we run more in the ICU? Should we have external people coming to guide decisions? Should we have maybe the family members helping us for that? And do you think that this is realistic? Or do you have, from your personal experience, ways to optimize how we are discharging patients from the ICU, either something like 1 hour after extubation or sometimes when the patients are terminally ill? So any comments on that? Maybe Claudio, maybe Maurizio, Charlie, Jozef?
Do you start?
I could start. During the terrorist bombings we had in Jerusalem, we had serious problems. And I used to let my colleagues take care of the patients being admitted, and I would try to discharge patients. And it was very, very interesting. Patients who we'd been spending days trying to discharge during one of these events, all of a sudden, everyone was very, very helpful in terms of discharging patients. So some patients are borderline and can be discharged to a regular ward. Some patients may not be able to be discharged to a ward, but there are maybe other specialized units where they can be discharged to, and that can be helpful. During COVID, we saw, as opposed to our usual practices of having 2 patients for each nurse, sometimes we had to stretch things and go to 3 patients per nurse, which was difficulty. But we managed. The care probably wasn't as good, but sometimes you have to do with what you have based on the numbers of patients coming in.
If I can add, Elie, to that, and also from some experiences that we had in Lombardy during the COVID outbreak in 2020, at the beginning in March, is that, often in this crisis, what happened is that the all healthcare facilities affected, and you have to stop a lot of the elective surgery, for instance, a lot of the elective activities. This makes available several healthcare workers, but these healthcare workers, of course, they don't all have experience of ICU. So when you have devices available, when you have beds available, you can increase the number of ICU beds, but you still need workforce. And the way you manage this workforce requires a lot of organizations, because clearly you need to have the intensivists, the people that are used to do their job, still to supervise other people, the experienced ICU nurses and so on. And so you can increase your teams. But we have to remember that getting those competencies is to become a specialist. It's not something that you can just have just in a couple of hours or in a few days. To be honest, this is one of the reasons why we're also doing some of this training. We spoke with our colleagues from Ukraine. They were telling us how can we provide some teaching and some training to some of these people. And it requires a lot of efforts also from the leadership of the ICUs. If I increase my number of beds from 6 to 12 or from 12 to 24, and maybe I have human resources there, it's obvious that I cannot provide the same quality that I would do in normal times. You're operating in a different mode, and it's very important that the leadership of the ICUs actually realize, and they are very open about this. Otherwise, you start to create moral distress, moral injury in people, because your team will see that they cannot provide the standard of care that they are used to. So I think it is possible to increase beds before going to triage to your normal set of beds. I think this is actually what happened in most of places. But in order to do that, you also have to understand that it's creating a major impact also on healthcare workers, and you need to find a way to support them and to be very clear about goals and about the fact that the quality of care that you provide in those moments is clearly different than what it is in normal times.
Of course.
Can I just add something to that, Elie, Maurizio? Because I think this is a very important issue. We had faced the same situation because in the Netherlands, even though we are not as good as the Scandinavian countries, patient care in ICU is something between 1-to-1 nurse-patient ratio to 1-to-2 when the patients are not very ill or at night. When this COVID, the first wave, the first surge started, we made it 1-to-4. And you can imagine what happened there. And we have done actually 2 things. One was within our hospital when I was the head of the department. The second one was at national level. The first one was that we have written a letter to the personnel and told them that these are very different and extraordinary times. We may not be giving the exact help to the patient which you are used to for many years and you are trained to, but if we don't do this, we may be having more death patients than we would be able to save their lives. and as the leaders of two departments of anesthesiology and intensive care, as the head of the department, we took every single responsibility of any complication which would happen. That have given some space in their minds to work in a different way. The second thing we did was national level, and we asked the health inspection teams that nobody would be found liable from any complications done under the circumstances of COVID-19. And the inspection, the health inspection has agreed on that. So normally in the Netherlands, if you make a mistake, there's a research and all these things just to see where you have done it, why did you do it, etc. I mean, looking for the core of the mistake was done, but they were completely immune of having any consequences from that during that period only. However, there is a but here, because the but part is that this worked on short term excellently. When we had the second surge, it worked a little bit, but with the third and fourth, you see that it really does not work anymore, because the people just work very hard. But when the crisis is very long, you see that they start to lose their faith. So I think there some psychological support would be extremely necessary and useful, because people can do such a change for a short time. And a short time, I don't mean 2 days, I mean months. But if it becomes a very long period, then you will see the bad effects on the moral injury on the of the people.
Thank you very much, Jozef. I think we are getting very close to the end of this webinar. We could speak hours more. Just a very quick question to end. Do you think that an external team, instead of the ICU people in charge, should make the decision, the triage decision to ICU? Or do you think that people caring for patients should make the decision? With the COVID-19, a lot of French hospitals have implemented these triage teams where external people, including some ICU people, but also people from internal medicine, nurses, doctors, and other specialties, making the decision of triage to ICU admission. Just a very short answer, yes, no. Charlie, what do you think?
So I think it's fine to have an external committee to decrease the moral distress, but they have to be people who understand the ICU triage process, and there have to be intensivists involved.
Claudio, any idea on this triage committee?
Yes, these duties for the medical emergency team and outreach team is something similar. And they generally, for instance, in my ICU, intensivists who work in the medical emergency team triage patients naturally. And this is what we did, even if unofficially, during the COVID pandemic in my hospital. I think it's a good idea.
Thank you. Maurizio?
Yeah, I think you will find different ways also according to the organizational setup before a crisis and to the cultural setup, that you have in the hospital, in the place before the crisis. But similar to Claudio, we had outreach teams assessing patients and basically deciding the escalation plans, and then the ICU team was different, but admitting the patient and treating the patient. So
the same for you, Jozef?
Yes, absolutely. I just want to make sure that every time there is a triage team, we had an intensivist in the team, as well as a surgeon and an internist. But for me, there is something more important here. What I wanted to say, and that is, the intensivist can work in intensive care. The same intensivist can work in the triage team, but not in the same time frame. So you can be working today in intensive care, tomorrow you are in the triage team, but you are not doing double work at the same time, which is conflicting with each other. That's what I meant.
Thank you very much, Jozef. I think it's time now to conclude this Solidarity webinar. I want to really thank our speakers, the panel, and from the bottom of our heart, be sure, dear colleagues from Ukraine, that we stand with you. We are with you, we support you, and anything we could do to support you would be done. And ESICM is very proud from this solidarity webinar, and we are looking forward to more training and more proofs of solidarity. Thank you very much, and have all a good evening.
Thank you.
Thank you. Take care.